Hope Cook with Dermcast.live. Today we're talking to Dr. Olushola Vaughn. Dr. Vaughn practices as a dermatologist in Wisconsin and has a special interest in vulvar dermatoses. Welcome, Dr. Vaughn.
Thank you, Hope.
I know you're excited to talk about vulvas.
I do love talking about vulvas.
All right, so I want our listeners to hear about the genius algorithm you use when you see a dermatosis of the vulva.
Thank you. So I think about the vulva in 5 big categories because I think it's helpful to know where you are, what thing you are looking at in broad strokes that you know how to proceed. And so the 5 big categories, there are many that you could come up with, but the 5 that work for me are inflammatory conditions. So the red vulva, the white vulva, so things like Lichen sclerosus or eczemas of the vulva. Infectious things, so Candida infections or herpes. And then neoplastic conditions, both benign and malignant. And then there's hormonal things which the GYNs kind of manage more than dermatologists do. And then there's nerve and muscle concerns, which we really see a lot in the vulvar space. Things like vulvodynia, where you really need to get pelvic floor physical therapy on board.
Yes, I was going to ask you about pelvic floor physical therapy.
Oh, good.
Yeah, so tell our listeners how that can help if you're having vulvar symptoms like itching or pain.
There are so many nerves that go, that area of the body is intended to be extremely sensitive. So there's a lot of nerve that goes into it and so much muscle, thinking about evolutionarily, the movement from like being hunched over to like standing upright. So much is going into that. And so all along that, along that pathway of just like nerves and muscles, there's so many places that problems can arise.
Yes.
And in the pelvic floor, just the musculature itself, if you've had a big baby, if you've had any injury, if you're just getting older, sometimes those muscles can become very weak. And what I found when I went to pelvic floor physical therapy, because I sent so many patients that finally I thought I should go and just see, like meet the person, like see what this is all about. And what I learned is that many women are actually doing their Kegel exercises incorrectly. So there's the strength, there's the contraction, but there's also the relaxation. And people don't necessarily focus on both of them. And also like moving through the hips and back while you're doing them is important. Who knew?
Who knew? We just don't talk about this.
No, it blew my mind. So I love pelvic floor physical therapy. And when I have patients who have especially vulvodynia, but also just, for many other reasons, pain with sex, just that area being so medicalized that sex is not fun anymore. Sometimes I'll just send them there, just talk to the pelvic floor PT, just see what they have to offer.
Yes.
And it has been life-changing for many of my patients.
That is such a good tip.
It's so my favorite thing ever.
Okay, so women put so many products on their genitals. What is one of the top allergens that you see? Contact allergens or irritant allergen?
Oh gosh. Well, the number one fragrance that is the culprit in women who are people who are patch tested with an anogenital dermatitis is fragrance.
Okay.
So, if you Google, sex lube, you'll find ones that are like flavored like strawberries, and I mean so many fragrances are in these products, and it's wonderful for many people. They don't cause any problem, but they cause a lot of allergies.
Yes, and I once heard it said that the vagina is like a self-cleaning oven, but people think they need to use all these products to like keep it clean or fresh or. So what do you tell your patients?
And what's also interesting about that is that there may be some like racial/ethnic predilection to that. Like certain groups of people maybe have like heard through cultural conversations that they should or need to douche or use these like hygienic products. And I mean, I always am talking to patients about how the vagina and the vulva, they're meant to smell that way. Like evolution has figured this out over centuries, like to make it smell the best way possible to attract someone of
pheromones.
Pheromones. I mean, so it's not, there are people who truly do have malodor of the genital area, and that's a medical problem that needs to be investigated and worked out. But for the vast majority of women, your vagina smells the way it's supposed to, and that's a great smell. The vagina is a self-cleaning oven. You don't need to douche. You don't need to use like cleansing wipes after. You're probably just fine.
Yeah. I love that. Okay, so you had the toilet paper test. Can you explain that?
When I have a patient who has what I think might be a contact dermatitis, I ask them to tell me everything that touches their vulvar skin. And I call it the toilet paper test because as they're going through the things, you know, they might come up with, oh, I guess maybe my underwear. Well, I use this like kind of bath and I won't make anyone feel bad, but some fragrance soap that I use in the shower. You know, they'll go through, you know, maybe a wipe that I use. And if they haven't said toilet paper, then I know that they haven't thought through everything. They haven't thought through their whole day. What all really goes on in that place?
Yeah, so do you put them on like a blend, like for 30 days or whatever? You have to use only these products?
Well, I'm not so strict about it because I know that people, I mean, some people truly have been using the same product for decades and it's never bothered them and they use it on their face and they use it everywhere. But the issue with that is that the companies can change their ingredients. They don't have to change the bottle. They don't have to tell you that they changed it. So just because you've used it forever doesn't mean anything. And so I usually will tell people, I'm not such a taskmaster about it, but I tell them, I want you to only use things that are really bland. And then the other thing, if we're really working on a problem, they have like a rip-roaring dermatitis, then I say, just give me 3 months. Give me 3 months and just put on gentle soap and water and these like treatments that I'm giving you and don't do anything else. Just let's see what happens.
Yes, I like that. And you mentioned plain Vaseline. Like that's,
oh my gosh. Like, yes, my favorite thing.
Yeah, just plain old Vaseline.
But plain old Vaseline, it's cheap. Nobody gets allergic to it. I mean, my grandma used it like everywhere on her body and she had amazing skin.
Yes. All right, so what are some other common things that you see patients use or do that you wish everybody knew?
Well, I think that people need to know about wipes. So people use a lot of wipes, and there's one wipe out there, like water wipes, where it's 99.9% water, and then grapefruit extract, like one, you know, which is like not my favorite. But if you must use a wipe, which nobody needs to, if you must, that's probably the one you want to use. All the other ones have, you know, allergens in them. And people honestly think that wipes are just so harmless because you put them on babies. You wipe a baby's
I've heard
butt.
that so many times.
But man, they're like my nemesis.
Yeah. Okay, and tell us about skin checks. Should we be checking the genitals?
Absolutely, absolutely. This is, you know, if I could look back on my career and think of like one thing that maybe I've done, it will be to have hopefully taught some of the trainees that come through my institution to look everywhere when you do a skin check. And so I think it's helpful to just have the words at the ready. I have a script. The script I use is, I always look at the anal and genital skin as part of a standard full body skin exam. Is that okay with you? To really normalize it, like I always do this. Is that okay with you? Because then they really, it's setting them up to say yes.
Yes.
You know, because I want them to say yes. And then I say, would you like a chaperone for this part of the exam? Because that's also important. I want them to be comfortable. People often then make a slew of like, you know, uncomfortable statements or jokes about how they haven't shaved or they weren't expecting it and they're not clean. And then I say, you don't have to impress me.
Yes.
You never have to shave for me. I'm never worried about, you know, smells. I just want to make sure you don't have cancer there.
Yes.
And I think that helps them to hear that too. So like as someone who performs skin checks, you look behind people's ears, you look, you know, in their armpits. Why wouldn't you look somewhere where someone could get like a melanoma and die from it? So yes, I always look.
All right, so that's the exogenous, and then there are the endogenous causes of vulvar dermatoses.
Yes.
Can you talk about those?
Yes, so I mean, there are many endogenous, so things that are coming from the inside. So things like, you know, in the dermatitis camp, we think of the endogenous dermatitis, that's atopic dermatitis, seborrheic dermatitis. And seborrheic dermatitis of the vulva is actually missed surprisingly often because we don't think of it. And it's especially hard when it's not other places. Like we expect if it's going to be here, then you'll also see it on the scalp or on the face. And so some of those can be really challenging. But it is important to be thinking about all of them and realizing that you a lot of the time have multiple things going on. There's an exogenous component, there's an endogenous, there's, you know, like the stuff that we're doing to the patient, there's the stuff the patient's doing at home. The vulva is so simple in some ways and so complicated in others.
Yes. Let's talk about lichen sclerosus, because I think a lot of us either miss it or patients don't bring it up. So tell us some things we should be looking for.
I can't count on, you know, all my fingers, toes, and yours, how many times I have just found lichen sclerosus doing a full body skin check. Patients, you know, one big myth is that patients are going to be symptomatic. They're going to be itchy and like you'll have a clue. Sometimes you don't have a clue, you just find it. So important that we're looking. And also that we're not just looking like let me take a quick peek. That like peek is such a terrible word, but just pulling down the underwear. Let me just take a quick peek.
Yes.
Like put their feet into the footrests and spread the labia and take a good look at that skin. Because we do find a lot of incidental lichen sclerosus, and it matters for their lives because it raises the risk of getting a cancer of the vulva, the squamous cell cancer of the vulva. So it's really important that we're evaluating and that we're treating and that we're educating the patient to know that this is important.
And what do you tell them if they have concerns about topical steroids long term?
I have also scripts for this. I think it's helpful to have a little bit of humor in it. One thing, for example, they will go to the pharmacist, and the pharmacist, or the default might say, apply a pea-sized amount. And so I always make the joke, well, they don't know how big your vulva is. Like, is a pea enough to cover your vulva or not? They don't really know. And so I say, use as much medicine as you need to get a thin layer on all of the skin that's involved. It doesn't need to be frosted like a cake, but you want all the skin to have a thin layer. And I think that helps because then they know, they know that we, as practitioners, that we are comfortable prescribing steroids and managing it, and that they're safe in our hands. And I also tell them that the ones that I've seen get in trouble are those that have taken their steroid and then just gone away, and I don't see them for like 2 years. That's when we have a problem. But if I give you the steroid and we have a plan, and you do the plan, and then you come back and we assess the plan, then you won't get into trouble with topical steroids. And
do you tell them this is a lifetime thing?
Yes. Again, when I look back, hopefully that's the one of the top things that I hope I have imparted to people throughout my career is that when you make that diagnosis of lichen sclerosus, that you have the conversation, you will be putting steroids on the vulva for life. That you set that up. Now, between you and I and our listeners, that might not be entirely true for every patient. But to set that expectation, because the risk of vulvar squamous cell cancer goes down so significantly when they apply steroid for life. Not a lot, just twice a week. And again, with one of my scripts, I say, just think of it the way that you think about brushing your teeth. You're going to brush your teeth for the rest of your life, till the day you die, and you're not mad about it. It's just something you're going to do. And same thing, if you have lichen sclerosus, you're going to put medicine on the vulva the rest of your life, and that's just your self-care.
Yes. Do you have them hold a mirror and show them?
Yes.
Exactly.
Yes. I mean, before I started doing this, can I think of a time that how many times did I ever take a mirror and look at my vulva and think about, like, what's the anatomy here? I mean, once when I was 13 or something, to be like, where's the tampon even go? But nobody's doing that. People don't know how their anatomy is changing. And they're not, some women don't like to look there. And I really try to normalize that. Like, why shouldn't you look there? This part of your body is beautiful. It's amazing. So complex. And, when it's diseased, sometimes they don't like to see the diseased skin. But, we have to get beyond that so that we can make the skin better. So all of our rooms have mirrors in them, and I love to whip that mirror out and show people exactly what I'm seeing and exactly where they need to put medicine.
And do you take photos also so you can?
Always photos.
Okay, good.
Yep. And I mean, that's always funny. Because your face is not in the, tell your vulva to smile. Your face is not in these pictures. They're on my phone, but they don't stay on my phone. No, I'm not posting them to Facebook.
Right.
All the jokes. Because how many times has a person had pictures of their vulva taken? Like, it's usually people's first time.
Right. Okay, and if you need to do a biopsy, can you walk us through your biopsy technique?
Sure. I very, very rarely these days do a punch or a shave biopsy of the genital skin. And that includes vulvas, penises, and anal skin too. And even true of the mouth, really. And the reason why is because I just find that I didn't have enough control of the tissue. Like, things were so squidgy, and they were just moving around, and I couldn't get what I wanted. And so these days I do a snip incision biopsy, which I love. The technique gives you a lot more control. You throw the suture through this, around the skin that you want to sample, and then you tent it up. You take a curved iris and you snip around it, not cutting the suture. And then you take that suture, the skin is hanging on it, you put that into your sample jar, your specimen jar, and then you have this intact suture, and you use that to close the defect that you made.
And it dissolves, right?
And it dissolves. Usually these days I'm using Vicryl Rapide, and I use, and it dissolves on its own over time. The patients, as far as having a 4 millimeter punch versus this kind of larger incisional biopsy, it really doesn't make much of a difference to them. It's going to heal around the same time. It's, requiring the same amount of care. But you can make the diagnosis much better when you have more tissue to look at. You really have so much more control over the experience of the biopsy itself. I mean, I really, like I said, I've converted completely.
Oh, good. All right, alternatives to topical medicines. If you have some reason you can't use topicals.
Yeah, you know, every disease, of course, is different.
Yeah.
But you brought up Lichen sclerosus, so I'll kind of focus on that. If you cannot do any topical, although we have new topicals now, there's like new, you know, there's steroid-sparing agents, there's JAK inhibitors, there's, you know, things that we can try. But my go-tos are generally methotrexate and acitretin.
Okay.
I like acitretin because of the potential protective aspect against cancer.
Yeah.
But you know, then there's the risk of, you know, it's a more expensive medicine, and there's the risk of hair loss. And a lot of my female patients, that's actually a big deal. And so methotrexate I like because, you know, it's cheaper, it's once a week dosing, there's benefits. So we usually have a conversation.
And you would do those long term?
Well, until I get the disease under really good control.
Yeah.
And then, as with all our patients in all aspects of dermatology, the goal is, ideally, could we wean them off of it altogether and keep the disease well controlled? That's the holy grail.
Yeah. Okay, so what else should we be looking for? If a patient comes in with a rash or hypopigmentation, like what do we do? Call you.
What else should we be looking for? I guess one thing that I think, like where we are uniquely able in vulvar dermatology to make a difference for people's lives, is not just looking at the skin, but thinking about the whole person in these scenarios. And we always say that, but I think especially with vulva, it's really important.
Yeah.
Because, you know, there are probably some racial and ethnic differences that, you know, we might not always be thinking of. We get stricken by them when there's a lot of dyspigmentation. Then it's like, oh, you know, it kind of like really stands out. But pigment is not always the issue. There's a lot of other things going on around, you know, cultural practices and self-image and social justice that have to do with the vulva. But also, especially in our younger women that have, you know, a vulvar disease, just helping them to remember that the vulva is supposed to be an area of joy for the body. It's supposed to be fun. And so, you know, supposed to, I shouldn't even, that's such a loaded term, but, you know, as they go through the medical system and so many strangers are looking at their vulvas, people are touching it, doing procedures to it, taking pictures of it. I mean, it's so intrusive. It stops being fun.
Yeah.
And so a lot of what I do is just have a conversation about who's your sexual partner right now? Are you interested in having a sexual partner in the future? Like, how are you feeling, you know? And just being like, you know, if anything, remember to get some joy from that part of your body, whether that be through masturbation or just, you know, taking a warm bath and just like touching that area, just like, hi friend, you've served me well and I'm here for you too. Just like having a moment with your body.
And you're giving them permission, which I think a lot of women need in many areas of their lives.
Totally.
Any other tips you wish we as providers knew when we're doing a vulvar exam or looking at a rash?
Any other tips? I mean, the biggest thing is to honestly look.
To look.
Because most people are just not looking. That is like probably going to be 80% of the battle in dermatology, is just getting people to look in that area. And then I think the other important thing is being really specific with your biopsy anatomy. You know, we would never get a biopsy result that just said ear. Right? Think of how, the ear is so small, but how many anatomic locations we have in there.
Yeah.
And then I get biopsy report after biopsy report, vulva. And they're cancers. Oh, wow. I don't know, vulva. It's like, well, where was it? I mean, sometimes it might have been 10 years ago and the patient doesn't even remember, you know. Or they healed so well we can't find the location anymore. There's no pictures in the chart. And all we have is vulva. Yeah. So like really being specific. Labia major, you know, left labium majus. You know, now I know exactly where the problem was. So learning those words.
That is a good tip. And you said you show them a picture too of like the anatomy so that they know exactly like what you're talking about. If you say apply this to your labia.
Yeah.
You know, and what's a labia?
Right, totally. And I have like a pretty dialed in like 60-second like anatomy teaching that I do for the patients. So I whip out my little piece of paper and I tell them exactly what the parts are, because those aren't words that people use at their dinner table. You know, those aren't words that parents teach their daughters, you know, so they don't know what their anatomy is sometimes.
Right, I'm sure you hear all sorts of lingo to
all
describe.
Sorts of lingo. And I have a daughter myself, and I'm like, you know, she'll, something about my vagina. I'm like, actually, that's your vulva. So now she knows that when we're talking about if there's an itchy part, it's on the vulva.
It's like, Mom.
She's going to be such an outcast
Yeah.
among her peers. That girl's weird.
Well, thank you so much for joining us. I think
Thank
this is
you.
a topic we just don't talk about enough.
Yeah.
And as providers, maybe we're nervous about asking, because we think we should know this.
Yeah.
So
It's
thank you.
uncomfortable.
Yeah.
But we got to make a change.
So thank you for coming today.
Thank you.
And I have some fun questions for you now.
Oh.
All right, so answer as quickly as you can.
Okay.
What is your favorite Halloween candy?
Twix.
All right.
Crunchy, caramely. Oh God, yes.
What do you like to binge watch?
I rarely have time to watch TV. Right now with my family, we're watching Lego Masters.
Oh, yay. All right, we're in Music City, so who's your favorite musician?
I have so many. I actually used to be in bands
You
before
did?
I went back to medical school. I played in bands in LA for about 10 years.
Oh, wow.
And I was like a pretty big music snob back then.
Yeah.
But I will share the most recent concert that I went to was one of my bucket list concerts, Peter Gabriel. I had never
wow.
seen him. And I always promised that if he came into, if he didn't die, and he came and did a tour, that I would go and see him. And so he came, and God, what a great concert.
Oh, good. All right, so if you weren't a dermatologist, what would be a fun alternate career you would have?
Can I be an artist? Can
Sure.
I don't know.
You can
I'd
be
probably,
anything you want.
I mean, that would require me to have actual art skills, which I have zero. So in this fantasy, I also am talented.
So you're an artist, a painter?
Yeah, maybe a painter or maybe like a pottery maker, like
Yeah.
making something tangible. That'd be fun.
I love it. Thank you, Dr. Vaughn.
Thank you.
Hope Cook with Dermcast Live.